This program is brought to you by Emory University.
And this is the very seminal paper to first report the clonal hematopoiesis in the 2014 in New England. So the clonal hematopoiesis is frequently found in the aged population. For example, the 10% of individual without blood disease actually carry this type of mutation, which are frequently found in the DNMT3A and the TET2 and AXXL1. So this is very consistent across the studies. The most frequent mutations in the clonal hematopoiesis include the genes in the DNMT3A, TET2, and AXXL1. And what is the health outcomes of clonal hematopoiesis? Obviously, these mutations frequently found in the myeloid leukemia. Therefore, this patient with a clonal hematopoiesis mutation are clearly associated with the further development of hematological malignancies and the associated with the poor survival after that. However, not only this hematological malignancy, but also this patient with the clonal hematopoiesis mutations are associated with a higher all-cause mortality. And this is actually explained by not only the hematological malignancy, but primarily due to the cardiovascular disease. That's why the only reason that I'm here with our cardiovascular disease colleagues. So the clonal hematopoiesis is clearly associated with the higher risk of coronary heart disease and also the early onset myocardial infarct. The one thing, this is the data from the cohort that are enriched relatively higher risk of cardiovascular disease. Particularly, this data is from the cohort from Pakistan, an Italian group, where they have the relatively higher risk of cardiovascular disease. So there are conflicting data coming from the different cohorts. For example, the UK Biobank data, which is the largest data set that currently we have. And the UK Biobank data actually suggested differently as opposed to what we originally reported in the two cohorts that I mentioned and reported in 2017. And then when UK Biobank data is looked at to associate between the clonal hematopoiesis mutations and the cardiovascular disease, actually they could not find a significant association. As you can see here, this is the data from the UK Biobank and Icelandic cohort, and they combined and tried to look at the association between cardiovascular disease and clonal hematopoiesis, but they could not find. Instead, actually, it is the association primarily driven by the smoking. So when they adjusted the smoking, and then the p-value significantly went down to the insignificance between the clonal hematopoiesis and the cardiovascular disease. So, however, when we looked at the individual mutations, so this is the data when it combined with the UK Biobank data and the US TAMMED and HLBI data, and then looked at the risk of heart failure in the context of individual mutations. So the AXXL1 and JAK2 and TET2 mutation is obviously significantly associated with the risk of heart failure, which is a sort of conflicting to the prior data, pointing out the individual mutation significance in the context of cardiovascular disease and heart failure varies, indicating TET2 and JAK2 mutation are playing a significant role of developing sort of a cardiovascular disease, particularly the heart failure. And also, when we looked at the established cardiovascular disease, the ones that we looked at before is the healthy individual, and then the developing the risk of cardiovascular disease in the context of clonal hematopoiesis. However, this study is actually looked at the established atherosclerotic cardiovascular disease and try to find out what is the risk of developing the secondary ischemic event in the context of clonal hematopoiesis, which revealed the patient with the cardiovascular disease and the clonal hematopoiesis actually have a higher risk of developing the secondary ASCVD and increased all-cause mortality, which is primarily driven by the TET2 and AXXL1 mutation as well as splicing mutation. So then this is also the data from German, where they looked at the heart failure with a reduced ejection fraction. So they looked at around 400 patients with the heart failure ejection fraction 30% and associated with disease outcome in the patient with the clonal hematopoiesis and the heart failure. So which revealed basically the presence of the clonal hematopoiesis associated with the poor clinical outcome and lower survival, as well as the higher variant allele fractions, for example, which defined here is greater than 3%. This data demonstrate inferior outcome in the patient with the clonal hematopoiesis and heart failure. So again, suggesting the secondary prevention, particularly in the patient with the clonal hematopoiesis and cardiovascular disease, may be more important than the primary prevention. And then another data looked at the clonal hematopoiesis and the preserved ejection fraction heart failure. And this is a sort of case control study data, and then they looked at particularly the individual with a younger age and predicted the risk of developing the heart failure preserved ejection fraction. So this data identified a particularly patient with a younger age, less than 65-year-old, and having the higher variant allele frequency greater than 5% is significantly associated with a risk of developing the heart failure preserved ejection fractions. So and also the other data, the recent data from South Korea demonstrated the CHIP is also associated with the atrial fibrillation, AFib, and particularly the mutation in the DNMT3A and the TET2 has a high risk of developing AFib. And they also Ben Ebert's lab, this is not published yet, but in the mouse model also demonstrate the TET2 mutations actually can generate more AFib in the mouse model as well. So this is a sort of a summary how we look at the CHIP in the context of the cardiovascular disease. Although the initial data from the seed at the Broad, they first demonstrate the association with the CHIP and the cardiovascular disease. However, when we looked at the various cohort, then actually the association between the CHIP and cardiovascular disease varies. And particularly in the cohort enriched for individuals with the higher cardiovascular risk factors, CHIP is certainly a risk factor, the increasing about the twofold of developing cardiovascular disease. And however, the healthy individual without the risk factors, the contribution of the CHIP is the unknown. And however, the particular individual mutation like a TET2 and the JAK2 mutation is associated with the higher risk across the board that the people have looked at. And particularly heart failure is the one have the higher association with TET2 and the JAK2 mutations. And also the secondary prevention that I mentioned earlier is also consistent in the patient with the clonal hematopoiesis mutation and underlying the heart disease had an increased risk of secondary event in the cardiovascular disease. So, and also the larger clones and the variant allele frequency greater than 5% or 10% actually increase the risk of developing cardiovascular disease. So the sort of summarizing what we are currently understanding in terms of the risk of the cardiovascular disease and the clonal hematopoiesis is sort of the focus on the secondary prevention in the context of the cardiovascular disease and the particular mutation like a TET2 and JAK2 may be worthwhile developing in terms of the next strategy. And now I'd like to go over some of the other, interesting in the health outcomes in the context of clonal hematopoiesis. This is data also the UK Biobank and other studies and combined cohort actually demonstrate the significant association between the clonal hematopoiesis and the lung cancer, and particularly TET2 and the DNMT3A. And also non-melanoma skin cancers had a high risk of the association with CHIP, clonal hematopoiesis mutation. And then beyond this, the hematologic disease and cardiovascular disease, obviously the clonal hematopoiesis is also associated with other diseases. For example, the COPD is very well established, and the type 2 diabetes, as well as the presence of the CHIP mutation actually reduce the risk of developing Alzheimer's disease. However, all those studies are based on the association study, where we really need to develop the evidence in the animal model or other means to make certain that the clonal hematopoiesis either can cause this type of biological consequence or sort of association. So my lab is sort of developing this strategy and the goals to the first, establish the biological consequence in the animal model in the context of the clonal hematopoiesis, as well as we are working on the characterization of this clonal hematopoiesis mutation at the single cell level. In the next couple of slides, I will give you an example how we can intervene this type of clonal hematopoiesis in the context of the inflammatory pathway inhibitions, and also giving another example of how we can establish the causality between the clonal hematopoiesis and the health outcomes that were seen and observed in the large cohort study. So the first part is about how we can associate, how we can intervene this clonal hematopoiesis. So this is the data from the various sources where it demonstrate the clonal hematopoiesis mutation is associated with the inflammatory pathway activations. In the left upper corner, this is data from the TopMed NHLBI study, demonstrating the clonal hematopoiesis mutation had a higher association with the inflammatory cytokines. For example, the TET2 is highly associated with IL-1 beta, and the DNMT3A and AXXL1 is associated with IL-6 and so on. And the left lower corner, this is the data from the monkey autologous stem cell transplant, the CRISPR engineered the TET2 locus to demonstrate TET2 mutated the clonal hematopoiesis is actually increased the levels of inflammatory cytokines, including IL-6 and IL-18 and the NLRP3. And the right side is a very known paper among the cardiovascular disease group. So essentially, TET2 mutated the hematopoietic cell can increase the risk of the arteriosclerotic disease. Actually, these mice develop the arteriosclerotic plaque, and also associated with the higher levels of IL-6 and IL-1 beta, indicating the bar graph upper right. And also, if these mice are treated with the inflammatory inhibitor, then the plaque development is significantly decreased. So indicating the clonal hematopoiesis mutation can activate the inflammatory pathway, which actually can inhibit it by the multiple agents that are currently being developed. For example, DFE890 is the NLRP3 inhibitors, and also canakinumab and gibokizumab is the IL-1 beta, the antibody, and also the CMK and IL-18, the antibody is being currently under development in the various settings, including cardiovascular disease and oncology. I don't think we need go into details about this canakinumab. You guys are the expert in our community about the canakinumab and CANTOS study, but canakinumab is monoclonal antibody, neutralizing monoclonal antibody targeting IL-1 beta. And the CANTOS is the study enrolled the stable cardiovascular disease patient and the testing the anti-inflammatory pathway blockade, the across the board, and randomized 3 different doses compared to placebo. And the primary endpoint was MACE. And then the study outcome was positive, and there was a dose-dependent reduction of the CRP and as well as MACE. And also, interestingly, there was incidental finding that the canakinumab treatment can lower lung cancer incidence as well as the mortality. And also this clinical benefit was augmented in the patient with the TET2 mutations. And then this is the sort of data when we look at the further from the hematology perspective in the patient with anemia and the clonal hematopoiesis. So this is the exploratory analysis in the CANTOS trial combining the genomic data as well as the proteomic data. Look at the outcome of the anemia in the patient with the clonal hematopoiesis in the context of IL-1 beta inhibition. So we included about the 4,600 patients with the genomic data, and also we did the SOMA scan. It's sort of the similar like All-Link, the proteomic study which can measure about the 5,000 proteins at the same time, and then we serially measured proteomic studies on those patients to determine the mechanism of actions of the canakinumab in the context of clonal hematopoiesis and anemia. So brief the discussion about the anemia of the chronic disease. It used to be called the anemia of the chronic disease. However, now it's more frequent term is anemia of inflammation, which actually the inflammation cytokine like IL-6 and interferon can they promote the differentiation toward to the myeloid disease, myelopoiesis, and inhibit the erythropoiesis, and also the inflammation can increase the reticular endothelial clearance of the red blood cells. So the sort of the mechanism of the disease is multifaceted and including multiple sort of the pathways being involved. And this is a sort of brief introduction of a proteomic study that we did in the CANTOS. The SOMA scan is the DNA-based platform to measure the proteins in the small volume of samples. And this actually take advantage of DNA oligonucleotide that can identify the specific proteins, which previously validated in the mass spec. So the SOMAmer can detect proteins in a very highly specific manner in the high throughput way. So the SOMA scan can actually measure about 5,000 samples in a single 50 microliters of biological samples. So this is the patient characteristics in the patient that we looked at in the CANTOS, the 4,500 patients, and the randomized between the 2-to-1 ratios between the canakinumab and placebo. As you can see here, the patient group is well balanced in the subgenomic study in the CANTOS, which included only DNA mutations study here, and then we see the higher the CRP and the CHIP mutation in the patient with the baseline anemia. And then this is the data try to find out which patient group has the higher chance of having the clonal hematopoiesis mutation. And this forest plot that as you can see here, the age and the presence of anemia and higher levels of cytokines were significantly associated with clonal hematopoiesis, which is sort of consistent with the previous data. And then we looked at the hemoglobin response in the patient with the clonal hematopoiesis mutation, and then stratified by the presence of anemia. In the patient with the concurrent the clonal hematopoiesis mutation and anemia had a higher response to canakinumab in terms of the hemoglobin response as depicted in the blue line here. And then this is the data from the patient with the baseline anemia and then stratified by the presence of CHIP mutation. As you can see here, the canakinumab treatment has significantly increased the levels of the hemoglobins in the patient with a clonal hematopoiesis mutation and anemia. However, the patient without the clonal hematopoiesis mutation did not respond to the canakinumab. And particularly, the individual with the TET2 mutation had the higher the response to canakinumab in this data set. And then we looked at the mechanism of action of canakinumab by looking at the SomaScan, our proteomic assay, to understand the mechanism of action. As you can see here, in the blue dot is the patient. This is the patient who received the canakinumab, and black is the patient who received the placebo. And the canakinumab treatment can suppress the hepcidin and the IL-6. The hepcidin is the erythropoiesis master regulator responding to systemic inflammation like IL-6, and particularly in the hepatocyte. Hepcidin is upregulated in the response to inflammation, and then the suppress the ion, the utilization in the erythropoiesis. So then the suppression of the hepcidin and IL-6 is correlated with upregulation of acetylcholinesterase, which is the most abundant protein on the red blood cell membrane, and also is associated with increased levels of hemoglobin. So basically, the canakinumab treatment can suppress IL-6 and hepcidin axis and enhance the erythropoiesis, of which we saw the hemoglobin response in the previous slide. And then we looked at the baseline signatures of the proteomic assays in the patient with first looked at the baseline proteomic profile between the clonal hematopoiesis mutation versus non-clonal hematopoiesis mutation. As you can see here, the inflammatory signatures in the left were significantly upregulated in the patient with the clonal hematopoiesis mutation compared to non-clonal hematopoiesis mutation. And also the high risk of the cardiovascular disease biomarker like a pro-BNP and the FDG and so on also upregulated in the patient with the clonal hematopoiesis mutation compared to non-clonal hematopoiesis mutation. And then we looked at specifically among those patients with the clonal hematopoiesis mutation and compared by the presence of anemia, and this is the lower panel. And the patient with the clonal hematopoiesis mutation with the anemia has an enrichment of the suppression of the enrichment of the inflammatory pathway, as well as a high-risk cardiovascular biomarkers compared to the ones in the patient with the clonal hematopoiesis mutation, but without anemia, indicating sort of at the baseline, the inflammatory signatures were progressively enriched in the clonal hematopoiesis mutation and anemia, and the less enriched in the non-clonal hematopoiesis mutated individuals. So then we looked at the response after canakinumab is given. So we looked at IL-6 and hepcidin, and also the inflammatory and immune response signatures in the SomaScan in comparing baseline and either month 3 or month 12. As you can see here, among the patients with the clonal hematopoiesis mutation and the patient with the anemia and clonal hematopoiesis mutation have a higher suppression of the inflammatory cytokine, including IL-6 and hepcidin, and also the higher suppression of the inflammatory pathway and immune response signatures measured by SomaScan when they were treated with the canakinumab. Sort of this is a summary of how we can intervene the clonal hematopoiesis. This data actually suggested there is a progressive enrichment of the inflammatory signatures in the patient with the clonal hematopoiesis mutation compared to the patient without clonal hematopoiesis mutation, and then this enrichment of inflammatory signatures will also enhance further in the patient with concurrent clonal hematopoiesis mutation and anemia, which actually qualified for the diagnosis of the CCAS by WHO. And again, the proteomic genomic studies can reveal the mechanism of actions and some of the biology behind this. And the CH mutation, clonal hematopoiesis mutations can actually intervene with the IL-1 beta blockade. And then I would like to switch gear to the another facet that our lab is currently investigating is about the clonal hematopoiesis and the solid tumors. This is the data from the UK Biobank and also the other studies from Boston also confirmed in a different data set, clonal hematopoiesis is associated with a higher higher incidence of lung cancer. So incidentally, the CANTOS study demonstrated that the IL-1 beta inhibition can actually reduce the lung cancer in a dose-dependent manner, as shown here. And then we went back to the CANTOS study where since we have the CH mutation, clonal hematopoiesis mutation data, and also the cancer incidence in those patients who were treated with canakinumab. So our hypothesis here is the treatment with the canakinumab can mitigate the risk of IL-1 beta-driven solid tumor in the patient with the clonal hematopoiesis mutation. So actually, this is true. So this is the data from the patient who eventually developed any type of the epithelial tumors and non-hematological malignancy in the patient who were on the CANTOS study. So, and then this is the cancer incidence in the CANTOS, and then the patient treated with canakinumab, particularly the patient with the TET2 mutation have the less incident, the non-hematological cancer in the dose-dependent manner, as you can see in the left graph. Whereas the patient without clonal hematopoiesis mutation, actually there is no difference between placebo and canakinumab. I would like to again emphasize this, that the TET2 mutated patient had a dose-dependent suppression of developing the non-hematological cancer here, which is sort of consistent with prior observations that the TET2 mutation have a higher association with IL-1 beta levels. So then when we looked at specifically in the lung cancer, so the first in the left graph, this lung malignancy is actually suppressed by the canakinumab treatment. So the red line is canakinumab arm, the blue is the placebo arm. So this is the data originally reported in the 2017. However, in the right panel, in the patient without the clonal hematopoiesis mutation, these lines are overlapped until the 3 years. So this difference that we saw in the 2017, the canakinumab can decrease the lung cancer incidence, actually explained by the patient with the clonal hematopoiesis mutation. For example, here in the DNMT3A and the TET2, and the canakinumab treatment basically wiped out any incidence of lung cancer, whereas a placebo group developed the lung cancer, as you can see here in the cumulative incidence of the lung cancer. So basically, this data demonstrate TET2 mutations are obviously involved in the lung cancer development, and the canakinumab treatment may suppress the lung cancer development, particularly in the patient with the DNMT3A and the TET2 mutation. So our lab is actually doing the molecular interrogations as well as the developing mouse models to see how this clonal hematopoiesis can contribute to this biological outcome. So this is coming from the CANTOS data where we compare the clonal hematopoiesis mutation versus non-clonal hematopoiesis mutation patient to actually, again, this demonstrate the clonal hematopoiesis mutation, the individual have the higher levels of high-risk CV biomarkers like a pro-BNP, IGF, BP, and the GDF. And also, interestingly, the immune regulators like a TIM3 and the TNF superfamily is actually significantly upregulated in the individual with the clonal hematopoiesis mutation. So that being said, we actually looked at the single cell, the sequencing data in the TET2 mutated mouse bone marrows. So this is the data from the TET2 mutated bone marrow compared to wild type in the aged mice as well as the younger mice. So one of the hypotheses is that the aging process actually can contribute to the IL-1 beta levels. So our hypothesis, not only TET2 mutation, but also the aging itself that can contribute to the change of the microenvironment in the bone marrows to contribute to disease outcomes. So again, the IL-1 beta is known to play a role in the development of myeloid-derived suppressor cells, which actually downregulate T-cell mediated anti-cancer immunity. which also can be marked by the CD84. So when we look at this data, the granulocyte lineage and the monocyte and the dendritic cell lineage are actually marked by the IL-1 beta as well as the CD84. So when we looked at the this data, then we compared this the MDS signatures in each cluster and in individual genotypes, including the mutated old marrow versus wild type old marrow, and versus the mutated young marrow and the wild type young marrow. So as you can see here in the first row, that we measure the myeloid-derived suppressor cell signatures in each individual clusters and comparing to each genotype, which demonstrated the mutated old marrow, the TET2 mutated marrow actually had the enrichment of MDS signatures compared to any of the other genotype. And also, when we look at the T cell signatures and NK cell signatures, then the TET2 mutated old bone marrow have a suppression of Treg signatures, whereas the NK cell signatures, NK cell activation signatures were enriched in the mutated old marrow. So indicating TET2 mutation does have the change in the immune regulatory landscape by having the upregulation of IL-1 beta, which leads to the expansion of MDSC, as well as the expansion of the Treg cells, and the concomitantly NK cell function is actually suppressed. So now we are looking at sort of the mouse systems, the reconstituting TET2 hematopoiesis in the context of lung cancer, so which we are going to explore soon. So then the last section that I would like to discuss is about the how to translate this to the clinic. And then our strategy here is to establish the clonal hematopoiesis clinic at the Winship going forward, or hopefully by the end of this year. So this is because we can actually maximize the cardiovascular risk reductions while we are collaborating with you guys, and also how we can intervene these disease conditions in both ways, not only from the hematological perspective, but also cardiovascular disease perspective, since we have a compound that we can test, for example, NLRP3 inhibitor. So our plan is we will do the next generation sequencing on the PBMC and identify the potential candidate for the CHIP clinic in the next couple of months. And the sort of criteria that we are putting up there was because the inflammatory signatures were significantly enriched in the patient with the CCAS, having the anemia, for example, then this can enrich the patient population who may have the clinical benefit from the clinical intervention. So the cytopenia and also the abnormal blood indexes like greater than 100 MCB and the 15 greater than 15 RDW. And the potential patient that we would like to have is not only, cardiovascular disease is very obvious, however, the COPD and autoimmune disease. And also we have the panel of the patients who underwent a curative therapy for the limited stage, the solid tumor, like the lung cancer or breast cancer, as well as melanoma patients. So we actually are undergoing sequencing those PBMC from those patients. And this is another example of how we can intervene this patient with a clonal hematopoiesis. I led this trial earlier, and then this is a sort of a trial in progress report that discussed at ASH last year. So basically, this is an NLRP3 compound, the DFB-890, and we are undergoing sort of a phase 1 trial to target the low-risk MDS. However, the same compound is being evaluated in the cardiovascular disease, and I don't know whether the Emory has participating in this phase 1 trial for the cardiovascular disease, but also I'm happy to connect you guys if you have a more interest in this sort of the phase 1, the first in human trials with the NLRP3 inhibitor. And that being said, I'd like to thank the leadership in the hematology division, and as well as the collaboration with the cardiovascular disease group. So happy to take any question.
I have a question. Am I audible?
Yes.
Um, so, so we know that with CH mutations and anemia, there's an increase in cardiovascular risk biomarkers. But is there any data on cardiovascular mortality in these patients with CH mutations and anemia?
No, I don't think so. So the anemia, we call the CCAS, the clonal hematopoiesis mutation, and anemia concurrently, we call those patients the CCAS. However, the current data set is actually included both the CHIP and CCAS in the, for example, the UK Biobank, they include all the CHIP and CCAS data all together. So this is something the have not been really evaluated, particularly in the CCAS patient, but current data actually include both the CHIP and CCAS. So this may be an opportunity to tease out between the CHIP and CCAS in the context of the cardiovascular disease outcome.
Thank you so much, Dr. Woo.
So just a few questions that came to mind. If you had 100 people with acute MI presenting, how many of them will have this, do you think?
Yeah, for example, the data from the CANTOS, that's a sort of a stable cardiovascular disease group patient that we saw about 7%. And however, the Vanderbilt actually reported that, they basically collect the PBMC from cath lab who came with a chest pain and then having the MI. And they identified more than 35% among those patients who having, active the catheterization. Then they identify about 35%, more than 35% of the cardiovascular, so 35% of the clonal hematopoiesis mutation. So the acute MI, they obviously, presenting higher risk. And also, I know where we are coming from, but also it's complicated by the presence of a history of smoking. So smoking can increase the cardiovascular disease as well as the clonal hematopoiesis mutation, as depicted in the most recent UK Biobank data. That being said, it will be dependent upon the cohort and risk factors in the particular the study cohort. So obviously, and having the MI definitely increase the risk of developing cardiovascular disease. The clonal hematopoiesis mutations. So I would expect higher than what we saw in the CANTOS or general population.
Mm-hmm. I mean, two comments to that. One is that there is a lot of literature in cardiology also to show that anemia has a bad prognosis overall. And it's been speculated why that is, but it could well be because of this. I'm not sure it's been studied. This aspect of anemia has been well studied. But even in an acute coronary syndrome cath lab population, those who have anemic have worse prognosis, independent of everything else. Mm-hmm. So I think, and we always wondered why that was, but maybe this is one of the reasons why that is the case.
I see. Yeah.
So something works. But in terms of your clinic, and final question, in terms of your clinic and the kind of population you want to see, we want people with just stable coronary artery disease or post an event, something like heart failure admission or MI, that would be an enriched cohort.
Yeah.
Plus some anemia, is that what we're looking for?
Yeah, exactly.
And then what would be the treatment?
So that's something that we have to develop. And the NLRP3 inhibitors, obviously, that we can start. And there is also clinical development on the IRAK 1 and 4 inhibitors, the same pathway. So the IIT is going to be in the setting of IIT. So like the NLRP3 inhibitors or the IRAK or some of the other, cytokine blockade. I think that's something that we can develop further.
Other questions?
So I just wanted to ask about sort of disease concordance, between cardiovascular disease and other diseases. You have anemia. Now, so I'm just thinking about cardio-oncology. and our patients with cardiac that we get from our oncology colleagues with cardiac disease. And in that cohort, have people studied CHIP in that specific cohort of those that develop cardiovascular disease that have oncologic disease?
Yeah, the current data, most relevant data is, to my knowledge, is from the Memorial Sloan Kettering, where they sequenced every individual with the solid tumors. And then they found about 30% of the clonal hematopoiesis mutation among those solid tumor patients. And then I don't think they particularly looked at the cardiologic outcome and association with, for example, ejection fraction decrease after chemotherapy and so on. However, having those patients, having the cardiovascular disease and the oncologic treatment actually can increase and enrich the presence of the clonal hematopoiesis mutation. So just by the numbers. So for example, in the general populations, typically we expect 5% to 10%, in the individual younger than 70. But then in the median age of 65, in the Memorial Sloan Kettering data demonstrate about 30% of the clonal hematopoiesis mutation in the solid tumor. So that will enrich the clonal hematopoiesis mutation from both angles, having the solid tumors and having the systemic chemoradiations, as well as the complication from the chemotherapy leading to heart failure or others. So there will be more patients with clonal hematopoiesis mutation, in particular those patients.
The question about smoking, as you said, the data looks like a lot of the mediation, at least in the general population, who's at risk for coronary disease and having events, is mediated through smoking. So has anybody looked at it the other way around? In other words, how much of smoking-related cardiovascular risk is mediated through this mechanism? Because we speculate it's due to endothelial function being bad, et cetera, but really don't know how smoking kills you in terms of cardiovascular disease. Because the smoke actually doesn't get there very much, like it does in the lung, right?
Right. I think, this is a sort of the area where the causality will definitely play a role. So which actually triggers which? For example, whether smoking triggers the clonal hematopoiesis mutation or the other way around. And there's basically three dots, right? The smoking, clonal hematopoiesis mutation, and the cardiovascular disease outcome. How they connected, I think there is no real data to connect the three dots more systemically. However, there is data based on the association between the smoking and clonal hematopoiesis mutation. Like definitely clonal hematopoiesis mutation is enriched in the smoking population, and particularly the DNMT3A mutation and AXXL1 mutations are significantly higher in the smoking population, whereas TET2 is not. So there is a sort of, depending on the clonal hematopoiesis mutations, the smoking may play a more role than the others, but those, connecting three dots never been really, systemically done to understand what causes what.
So are you suggesting that the initial data that was all very exciting about all these three mutations being a determinant of acute coronary syndrome, et cetera, from the broad, that data from Harvard, was that not ever adjusted for smoking? Was that not adjusted for smoking? That's what
that's adjusted smoking. So the age and the smoking history and those things are adjusted. But still, that data suggested, strong association. However, UK Biobank data was not. So I think there are more than smoking, but it's data's data.
Yes, one more sort of bizarre question. So given the inflammation link, and what about have people looked at, so statins have these pleiotropic effects that are sort of anti-inflammatory. How do they fit into all of this? You know, because statins have these mysterious effects outside of atherosclerosis that we can never, you know, we have lots of theories about, but is there any relationship there in terms of perhaps more efficacy in the CHIP group or relationship to CHIP?
I don't know. So best data I would think is probably CANTOS. So there is no control group that case, right? Everybody's taking statin and is maximized all the medication for cardiovascular disease. And that being said, the statin effect on the clonal hematopoiesis mutation, they speculated, I would say it's about the same because, our data from the CANTOS and the other data, the presence of a clonal hematopoiesis mutation is about the same. And the clinical outcome, obviously, we have to look at separately, but, I don't know, honestly. But this is something that you can look at and investigate.
I mean, a lot of these can be tested, at least in these large studies like UK Biobank, right? The kind of questions that we're asking are addressable, at least clinically.
Yeah.
So one more question, because we've been struggling with this, is should you do sequencing to do CHIP, or can we do this from GWAS, like what we've been attempting to do? Do you have a bias one way or the other?
Well, after UK Biobank data and the TAMMED data, there is a guideline how we can call the clonal hematopoiesis mutation based on the panel sequencing. So because the GWAS can sequence every genes, right? The whole genome and whole exome sequencing can sequence every gene. However, depth of sequencing is limited. Like we can probably maximize up to like the 50x whole genome sequencing. However, this CHIP mutation actually only occur probably less than 100 genes. So when they looked at the whole cohort from the UK Biobank and the TAMMED and HLBI, they actually concluded that CHIP mutations are 99% of the CHIP mutations occur less than 50 genes. So there is a tail. The majority of the mutations, the 75 mutations are occurred in 3 genes. The NMT3A, TET2, and AXXL1, and that there is a long tail. However, that tail stops after consideration of 99%. That tail stopped about 75 genes. So the current guideline is actually the DNA sequencing with a myeloid panel, including 75 genes, which can cover more than 99% of the CHIP mutations that were found in the large cohort study. So one of the benefit of the panel sequencing, actually, we can sequence deeply enough to detect more rare alleles, like less than 1%. The whole genome sequencing, obviously, we cannot detect above like a 2% or 5% of the variant allele frequency, whereas, this panel sequencing, we can detect less than 1% of the variant allele frequency. Then the next question is, what is the clinical implication of the lower the disease burden? Which many data suggested, and not necessarily there is a huge the clinical implication on those patients. However, at least we can tease out the lower variant patient versus a large variant.
So what's the incidence of this? So for example, you tested me on negative or less than 5%. When should I get tested again to know whether I've now developed a CHIP?
It depends on the mutations. And because the mutation kinetics actually measured through the various cohort. So it actually, the expansion rate varies between the mutation. For example, like a TP53 mutation and FF3B1 mutation, splicing factor mutation, actually they expanded very rapidly. Whereas, the NMT3A mutation is just there and then typically not, expanded very, very much. And the TET2 is sort of gradually expanding over time. So there are 3, mutation groups that we can look at, how frequent we have to follow. So depending on the tier of the mutations and the type of the mutation, we can actually devise how frequently we can follow that up. For example, like a TP53 mutation, current guideline is actually we can sequence them, annually. So that's sort of ASH, the hematology guideline we don't have to marrow them for bone marrow exam that is not necessarily be done. However, at least the sequence, by every year or every other year to see the clone expansion. However, TET2 and the other, DNMT3A, those clones doesn't have to be followed that frequently.
Any questions online? If there's no other question, then thank you very much.
Appreciate it.
The preceding program is copyrighted by Emory University.